The influence of the Detrusor underactivity on female stress urinary incontinence surgery outcomes is not pretty clear. And we have no standardized parameters of urodynamics to assess this in women. But many criteria have been proposed. And in our study, we used very strict criteria proposed by Zhang to assess outcomes of women with Detrusor underactivity underwent middle urethral sling for stress urinary incontinence. This is a multi-center prospective study still ongoing. All women were naive for stress urinary incontinence surgery, and we had two groups of women, one with Detrusor underactivity and the control group without Detrusor underactivity, and these were our exclusion criteria. All women had preoperative urodynamics. We assessed the postoperative urinary retention and the surgical outcomes after 1 year follow-up with an office evaluation. At the moment, we have two groups of 34 women each. The rate of postoperative urinary retention in the Detrusor underactivity group was 35.3%. Of these women, 83.3% had a spontaneous resolution within 1 month, and the two remaining, after counseling, decided for an early surgical treatment with TAP incision within 1 month. In the control group, only 3 women had postoperative urinary retention, and 2 of them decided for an early surgical treatment with TAP incision within 1 month after counseling. At 1 year follow-up, we have same results, same surgical results, with same rate of stress urinary incontinence recurrence of 11.8%, of de novo urgency of 5.9%. No women has indwelling catheter or is in intermittent catheterization. The peak flow fairly decreases only in the control group. The mean post-void residual urine fairly increases in both groups, but if we consider as a percentage of the bladder volume, slightly decreases in the Detrusor underactivity group and increases only in the control group. And urinary symptoms significantly decreases in both groups, but are still higher in the Detrusor underactivity group. So the Detrusor underactivity was a risk factor for transient postoperative urinary retention after middle urethral sling, and it was 4 times higher in the Detrusor underactivity women, but resolved spontaneously in these women. Of course, we don't know for the women who decided for an early surgical treatment. The Detrusor underactivity didn't affect surgical outcomes at 1 year follow-up. And preoperative urodynamics is still useful to select these women that are at higher risk of postoperative urinary retention, but there is still the problem on how to select these women because we don't have standardized urodynamics parameters, and this preoperative diagnosis may be useful in the counseling, in the postoperative management. Of course, we have some limits in our study, the low sample size, the long-term follow-up, but the study is still ongoing, and the patient who decided for an early surgical treatment. Thank you.
This is very interesting. We've always been wondering if those people were at high risk of retention afterwards. The problem here was your study that you know the urodynamic information going into the operating room, which may change how you do the procedure. So an ideal study would be for you to do the urodynamic, not know the findings, do the procedure and look at your outcome. That would really tell us more of the story, because I'm sure in the hand of expert people, having this information change the way you do it. We explored that in our prior UITN studies. And only if you're blinded can you really figure out the outcome of these types of projects.
Oh, no, surgeons were not blinded to the urodynamics results, but all women had a very proper counseling, and we didn't change our strategies on urodynamics findings.
Thank you for your presentation. I'm Vincent C. from Australia. In your post-operative peak flows, did you look at the curve pattern of the flow after the sling? Because you could report Qmax, which is better than pre-op or the same. Was there a curve pattern different?
Okay, I don't have this data now in this presentation, but this is a point.
You state that there is no gold standard for measuring Detrusor underactivity. Could you please comment a little bit on why you choose P Detrusor Qmax and not, for example, a flow, milliliter per second, or other options?
Okay, it is the choice is not easy, of course. I think that each choice you can do has something good aspect and some negative aspect. Because if you choose stricter parameters, you can lose some patients and include in different way patients. But if you use larger criteria, you can include some patients as underactive patient that are not, so you can have some bias. So in this first study, I prefer to use the stricter criteria to be most selective as possible in the selection of the Detrusor underactivity women. I know that using this criteria, we can lose some underactive patients, of course, but this was our choice.
In your group of patients, which kind of sling you perform, retropubic or TOT?
Both
Because
of them.
This is
Yes.
make some difference
Yes.
in terms of pressure flow study.
Yes, but
Later on.
this was not the surgeons were free to choice.
There is no difference in terms of.
There is no difference. I have I have not here the sub-analysis, but the sub-analysis of the different surgical technique didn't show any difference. But the numbers are still low, so the study is still ongoing. So I hope in a couple of years to have more data, but the enrollment is difficult because the criteria are so strict. But
I understand, but this is very important message to do, because for a patient with voiding dysfunction, doing a retropubic approach could make the difference compared to the TOT. TOT is more ready to facilitate the voiding phase compared to the retropubic.
Another point is that these women, the women with Detrusor underactivity, at 1 year follow-up, still urinate at the same way. So maybe they have a balanced condition that we don't know if it's really pathological. So this is another problem. Not time to.
Okay, thank you. Thank you.